I will talk about tumor lysis syndrome. I don't know how frequent you see a case of tumor lysis syndrome, but actually in our country and city, we see them a lot. It is not working. Okay. This is my talk outline. Actually, I will talk at the very basic level. I will talk about pathogenesis and diagnosis, prevention and treatment. I will start by pathogenesis and diagnosis. It's all about the cell of the tumor, cancer cell lysis. We know that cancer cell lysis actually, the cancer cell lysis occurs with the cytotoxic chemotherapy or with the radiotherapy, but it may occur spontaneously. It is very rare, but actually it may occur with very large burden tumor, and actually also can occur with hematological malignancies. The cell lysis will cause the intracontent of the cell to be spread into the serum, causing the manifestations and complications of the tumor lysis syndrome. Our patient will have hyperkalemia due to the extra deposition of or extra high level of potassium, hyperphosphatemia, hypocalcemia. The hypocalcemia mainly is because the level of the phosphate will attach to the calcium, causing calcium deposition and causing hypocalcemia. And then we have the nucleic acid breakdown, purine catabolism, that at the end it will give high uric acid level, and we know that the uric acid level solubility is very low, which will cause many manifestations. Again, and this is why are involved in this case, that the patient will have renal dysfunction. What are the pathogenesis or the steps for this patient to have renal dysfunctions? It's not only about the uric acid. We have multiple factors that we have to work on to know how to prevent and how to treat patients with tumor lysis syndrome. The renal dysfunction mainly, or not mainly, but one of the factors is the uric acid itself. We may have uric acid nephropathy. Then the next point will be, and this is very slow. I will stand here. Then we will have nephrocalcinosis. Nephrocalcinosis because, again, the phosphor will attach to calcium and deposits in the kidney. Then we may have obstructive nephropathy because of the same causes. Then one of the least important, but it is present, there is a little evidence that it is present, that we may have then seen nephropathy due to allopurinol therapy that I will mention later as the site of the action of the allopurinol. Okay. The hyperkalemia, what are the manifestations that the patient may be presented because of hyperkalemia? We said now why the patient had renal dysfunction. The manifestations of hyperkalemia, as we all know, and the most important and the most dangerous are arrhythmias and ECG changes. And regarding hyperphosphatemia, we will have a secondary hypocalcemia, the same issue that we see in cases with rhabdomyolysis, and renal failure, seizures, and also rhythm abnormalities. And finally, the hypocalcemia will cause tetany and arrhythmias. So it's not all tumor lysis is not all about the heart of the kidney. It's all also about the heart. As a complication, you may have many types of arrhythmias, very dangerous arrhythmias, and fatal arrhythmias. Okay. So how to diagnose? This is the pathogenesis. This is a general presentation. How to diagnose? We have two types of diagnosis: clinical diagnosis and laboratory diagnosis. The clinical diagnosis, as I said now, we have from Cairo Bishop definition to 2004, we must have at least two of these presentations. Uric acid more than normal range, and this is important, or even it may be in the normal range, but there is a 25% increase than the baseline. So it is important to know the baseline of the patient before the cancer chemotherapy or radiation, and to compare the post-treatment level 2. And it may be at the initial time that it is within normal range, and it will increase later. So a 25% increase in uric acid, potassium, phosphate, or decrease in calcium, it will diagnose tumor lysis syndrome. We need at least two of these features between 3 days pre and 7 days post. I told you pre because the tumor lysis may occur spontaneously even before starting the treatment. And we have clinical diagnosis. We have at least one, we must have at least one of AKI, arrhythmias, or seizures to diagnose tumor lysis syndrome. So this is all about pathogenesis and diagnosis. The most important point in our job as a nephrologist mainly is prevention. Whatever the topic we are talking, we always say that prevention is the best and first line that we must to achieve. So how to prevent hemolysis syndrome? Actually, this is mainly the job of hematologist. It's very rare to see a hematologist that consult a nephrologist before giving a radiotherapy or chemotherapy to a patient who is at high risk to develop hemolysis syndrome. But actually, we have to be involved in these cases. There must be whatever a protocol or whatever between the nephrology department and the oncology departments to diagnose patients of high risk, because high risk patients have a higher risk to have Timolasses syndrome, and the procedure of prevention must be given to the patient early as possible. How to prevent? First, and the most important, as the common situation in different acute kidney injuries is hydration. Identify the risk. You have to identify the risk of the patient. There are tumors that have high risk for Timolasses syndrome, tumors with high cell proliferation rate, high risk cancers, tumor with a size more than 10 centimeters, and the chemosensitivity of the patient. This is a classification that is known more by the hematologist and the oncologist about how to consider the type of cancer, high, intermediate, or low. The patient with higher risk must be identified and must have a good preventive measures to avoid the development of Hemolysis syndrome. Also, there are patient-related factors. These are by tumor-related factors. Patient-related factors. There is a patient that is at high risk for development of Hemolysis syndrome. If the patient has pre-treatment hyperuricemia or hyperphosphatemia, the patient is already has nephropathy, oliguric, is receiving nephrotoxin, or inadequate hydration. And actually, I think it's very rare to find a patient with no at least one of these risk factors. So I may consider most of the cases will be between moderate risk and high risk to develop tumor lysis syndrome. Okay, the most important point for prevention of Timolasses syndrome is dehydration, as it is the scenario in contrast-induced nephropathy and many other situations of contrast of acute kidney injury. Dehydration may be by sodium chloride, by glucose saline. There is no evidence which one is better than the others, but actually dehydrate the patient with sodium chloride. But it is important to see the volume condition of your patient. Your patient is olivuric and overloaded, so the dehydration must be less. But it's all about fluids. There is some papers or literature talking about diuretics, to use diuretics in this patient to maintain urine output. Actually, this may precipitate hyperuremia and may predispose to Timolasses syndrome. So diuretics has no role except for if the patient is very overloaded. I think this is a condition in all acute kidney injury situations. Okay. This is regarding hydration. What about prevention of uric acid formation? If the patient has low risk to moderate risk, and that's why it is important to stratify the patient according to presentation. If the patient risk is low to moderate, you can give the patient allopurinol or ficoxstate that inhibit the xanthine oxidase. You can give it maximum by 800 milligram per day with the allopurinol, and you can start it by 2 days prior to the therapy. If the patient has high risk, at this include high risk for Timolasses syndrome, it's better for the patient to receive raspuricase. I will talk about it in the management now, about raspuricase, but it's a very expensive drug, but very effective to lower the uric acid level, as it will convert the uric acid to the more soluble allantoin, and I will talk about it now in the treatment. Okay. What if the patient called Timolasses syndrome? You know, the patient diagnose the patient as Timolasses syndrome according to the clinical criteria and the investigative criteria that we mentioned. What is the treatment? Again, the treatment must be, first of all, I will talk hydration, if the patient can take fluids. And the most important, we must make cardiac monitor. We have many risk factors here for arrhythmias in our patients. So there must be cardiac monitor, maybe the patient admitted to the intensive care unit, follow up the level of the calcium, for potassium for hyperkalemia, be aware of hypocalcemia, and the same situation in case of rhabdomyolysis. We will not correct hypocalcemia because by correction of the tumor lysis itself, the level of calcium will increase gradually. While when you correct the hyperphosphatemia, the hypocalcemia will be corrected. So you don't need to correct hypocalcemia except if there are manifestations of hypocalcemia. And the same idea and situation we always see in cases of rhabdomyolysis. Again, as I said, volume expansion is the key to maintain high urine output, to avoid the uric acid nephropathy, the nephrocalcinosis, and to avoid the obstructive nephropathy. Continue the aripiprazole that you started before, and the most important, not the most important, but one of the most important points, alkalinization of the urine. Theoretically, if we made alkalinization of the urine, this will increase the solubility of uric acid. But take care, because alkalinization of the urine will precipitate more hypocalcemia. It is important, and there is no evidence that the alkalinization of urine treated Timolasses syndrome better than without using it. And again, there are three common arms in treatment that are common between rhabdomyolysis and tumor lysis. This is the third one, which is the alkalinization of the Okay. What about rasparicase? It is a recombinant form of enzyme urease oxidase that is present in most species, but it is not present in human. It oxidizes uric acid to a soluble allantoin, and actually its effect is very rapid and very strong. It gets the uric acid down within a very limited time, actually within 4 hours, to undetectable. In my site of work, we don't prescribe rasparicase as a nephrologist. The hematologist or the oncologist have the experience and prescribe it, but really it is very effective. It is available to be given in intravenous infusions. No dose adjustment required in renal impairment. Its side effects are rash, GIT upset, and headache. Hemodialysis, finally, if the patient is not responding to the treatment and if there is any indication for the dialysis in AKI that we all know, refractory hyperkalemia, refractory metabolic acidosis, refractory volume overload, or if there is uremic manifestations. My take-home messages: what are the risk factors for tumor lysis syndrome? Large tumor burden, high lysis potential, intensity of chemotherapy, marked increase in LDH, pre-existing CKD or AKI, hypotension, volume depletion, nephrotoxin exposure, and finally, acidic urine. What about laboratory diagnosis? At least 2 within 24 hours, or before or after the presentation of the patient. Phosphorus, high phosphorus, or more than 25% increased, high potassium, or more than 25% increased, corrected calcium less than 7, or more than 25 decreasing, uric acid increased also more than 25% than the baseline, or more than 8. At least one clinical criteria: kidney injury, arrhythmia, or seizures. And finally, the management in steps: aggressive intravenous hydration, maintain high urine outflow, medical management of electrolyte abnormalities, uric acid therapy, allopurinol or rasparicase, and finally hemodialysis for refractory hyperkalemia, symptomatic hypocalcemia, or any other indications. And thank you.